All right, welcome back to Fluid and Electrolyte, Hyperkalemia, and Acute Kidney Injury Part 2. So we're going to start at clinical manifestations. What your book does here is talks about the phases of acute kidney injury and uses three phases. There are some references that will have four phases for you. Your book goes with three. So the initiation phase is several hours to a couple of days. And let me tell you how quickly this goes. If your patient has less urine output than zero point 0.5 mils per kilo per hour for 6 hours, your patient is in acute coronary or in acute kidney injury. 6 hours of a urine output less than 0.05. That is how quickly this goes. What happens in this initiation phase is they're unable to compensate for the diminished renal function, and they will exhibit some signs of acute kidney injury. They're going to have decreased urine output. The good news is it's potentially reversible at this stage. They may also be asymptomatic. They're going to have decreased urine output, but they may not have those overt signs and symptoms that we see with them. So it's imperative that we pick this up. Patients with acute kidney injury have mortalities up to 75% increase. And it is so common in our critically ill patients. We just see it all the time. So what the maintenance phase, damage is established. The urine output's at its lowest. This does last between 8 to 14 days and can last as long as 11 months. Because here's the deal. If you have acute kidney injury and it becomes longer than 1 year, you now have chronic kidney disease. So acute kidney injury is from several hours up to a year. Beyond a year, you are now chronic. The kidneys cannot effectively eliminate their metabolic waste, the water, electrolytes, and acids. So we have lots of problems. We have hyperkalemia. We have fluid volume overload. They're going to be in metabolic acidosis because the kidneys can't produce bicarb. They're going to have azotemia. They'll have hyperphosphatemia. I always have a hard time with that. So their phosphorus is high. They will also be hypocalcemic because phosphorus goes one way, calcium goes the other way. They can have confusion, disorientation, agitation, lethargy, hyperreflexia. They could have seizures, coma, all of which is related to all of those toxins in their blood. Anorexia, nausea, vomiting. Decreased or absent bowel sounds. Some may be non-oliguric and have some normal output, urine output of 1 to 2 liters per day. Their lab work is still abnormal even if they are making urine because they're getting rid of volume, they're not getting rid of waste products. Okay, so in the recovery phase, we have renal tissue. The renal tissues recover and they repair themselves. We have an gradual increase in urine output and improvement in the renal lab value. So I expect their BUN and creatinine to come down. And they may have a diuretic phase. And so this is how I think of it because this is actually important. Those kidneys wake up and go, oh man, I got to do a job. Look at all this fluid. I need to get rid of all this fluid. And they may diurese a lot, which would put the patient at risk for dehydration and knock out their kidneys again. And this phase can take 4 to 6 months because your kidneys are rather slow. So the phases are going to help you understand the patho of what's going on with your renal failure and can help you look at some clinical manifestations of what these patients have. I will say that in pre-renal failure, they do tend to be hypotensive. In post-renal or in intrarenal failure, they can be hypertensive. They will be tachypnic because they are blowing off their acid of their PaCO2 because inherently they are in metabolic acidosis, and the easiest compensation is to blow off PaCO2 to get rid of that acid to try to get that acid-base balance back to normal. We've got collaboration. We will certainly have healthcare providers, nephrologists, pharmacy, RT, case managers, social workers, dietitians are all going to be there. So let's talk about diagnostic tests. So we may just do a regular UA. We could do a 24-hour urine, so you should know how to do a 24-hour urine. We could look at just a basic metabolic panel, CBC. These patients do tend to be anemic. Look at ABGs for metabolic acidosis. The two labs that are most important are BUN and creatinine, and normal BUN's 10 to 20. BUN by itself is not specific to renal. It's for protein metabolism, and it goes up for lots of different reasons. High protein diets make it elevated. Dehydration makes it elevated. Creatinine is the normal, the one that we want to look at, and normal values are 0.7 to 1.4, so 7 to 14, put some decimals in there. A critical lab value is greater than 4 for this. Now, I've seen creatinines of 20 in chronic or in acute kidney injury, but we're certainly concerned when it's higher than 4. Then we have a BUN creatinine ratio, and a normal ratio is 10 to 20. It's how much BUN in combination to the ratio of creatinine. And what the BUN creatinine ratio is if you think of a scale, like the scales of justice, and if I've got BUN on one side and creatinine on the other side. So in pre-renal failure, what happens is my BUN actually goes up first, followed by my creatinine, and it makes the scales tip to one side, so you'll have an elevated BUN creatinine ratio in pre-renal failure. In intra-renal failure and post-renal failure, your BUN and creatinine go up at the same time. So your BUN and creatinine renal failure are in post-renal and in intra-renal failure, your BUN and creatinine go up at the same time. So your BUN creatinine ratio is normal. And the reason this is important is, remember, pre-renal that's gone on long enough can cause intrarenal failure, and it'll actually help us determine, is this pre-renal failure or have they fallen over to intrarenal failure. We can also do things like renal ultrasounds, CTs, biopsies, those kinds of things to look at those kidney function. Okay, so let's talk about pharmacology for these patients. So we can give them diuretics, and they do need diuretics. We'll need to control their blood pressure. They do have increased gastric acid, so things like antacids, H2 blockers, PPIs are important. They're going to be hyperkalemia. So they're going to have really high potassium levels, and that can be life-threatening, just like low. So the first drug that we can give them is sodium polystyrene sulfonate, and that's called Kxalate. And we can give it orally or rectally. So I've put it down OG tubes, and I've literally poured it in a glass and had somebody drink it. And when we give it rectally, we do that with an enema. We do need them to retain it for as long as possible, and it will pull out the potassium. It's kind of caramel colored. It's kind of thick. It has a weird smell to it. It reminds me of caramel, and not in a good way. What else can we do? We can give D50, 50, and regular insulin IV push. What that does is it forces the potassium from the blood out into the cells and drops their potassium level. We can also give calcium gluconate or calcium chloride. That may be given as an additional order with your D50 and regular insulin. And we could give a diuretic furosemide, because that's a potassium wasting diuretic, if their kidneys will respond to that, because we know when these kidneys don't work really well, we have trouble with some of our medications. If they are in metabolic acidosis and their pH is less than 7.2, we will give them bicarb. We can give that as an IV push. Or if they are maintaining that and have other reasons like sepsis that they're in metabolic acidosis, we might start them on a bicarb drip. And we do need to restrict their fluids because they will have fluid volume issues. All right, so I just gave you a little brief history about renal diet. We need to give them enough energy, protein, and micronutrients to maintain homeostasis and prevent catabolism. We need to limit their protein, sodium, potassium, phosphorus, and fluids. They'll need some supplements like vitamins, folic acid, iron. They may need to increase their calcium. You might get a diet question on the NCLEX, and they're probably going to pick something that's a little harder than a diabetic diet and go with a renal diet. So in your notes, I did include foods to avoid and foods you can eat. A renal diet's very difficult. This is where we really do need to call our friends, the dietitians, to come in, because most of these patients actually are diabetic and have other issues that we have to add into the diet. But you should know a basic renal diet for them. And it's not just limiting protein, it's picking appropriate foods. All right, so let's talk about treatments. While we do this, while we talk about medications in these patients and what they look like, you should be able to think about what's important for you to do as the nurse. So sometimes we just watch them. Sometimes they'll say they have renal insufficiency, and what that means is their BUN and creatinine are slightly elevated, and we're just like, okay, we're just going to kind of watch this. We're going to see what happens. We're not calling them acute kidney injury yet. We're just going to watch them. Treatment is dialysis. So we can do hemodialysis. It's the most frequent one, and we do need vascular access. So if this is an acute problem, we will do a temporary catheter of 2 or 3 lumens. We call those Quinton catheters. So there'll be IJ or subclavian put in. Occasionally we'll do femoral, but femoral catheters are a bit problematic. It's a dirty area, and certainly they can't get up and move. If they have a fistula or a graft, that's for long-term dialysis, so that does tell me that this is a chronic patient. But you will see chronic dialysis patients with a temporary catheter because their fistula or graft has failed, while we are putting new ones in, waiting for those to heal because you can't immediately use them. We will put a temporary catheter in and do dialysis on them. So regular dialysis is done over the course of a couple of hours, and basically they pull about 3 liters off. Chronic patients will go 3 days a week to have this done. Patients can do it at home. That is becoming more and more common, that people are doing their own dialysis at home and not having to go to the dialysis center. If we are starting dialysis on a patient who's in acute kidney injury, we may be doing dialysis every day. So the dialysis nurse will come in and set up and take care of that patient and do the dialysis for us while we're still taking care of the patient. The good news is sometimes if we need to give blood products, we can just hand that over to the dialysis nurse and they take care of that. They just put it through their dialysis machine, and that's really good for us. Patients could be on peritoneal dialysis. That is more chronic renal failure. I wanted to call it back into your mind since we're just talking about renal failure. And that is gradual removal of excess solutes and fluid done through the peritoneal cavity. Their highest risk is peritonitis. So you should have learned about this before, those signs and symptoms of peritonitis. If they put 2 liters of fluid in, what do I expect to come out? At least 2 liters should come out. If they develop peritonitis, they have to stop peritoneal. They will come in and get a temporary catheter and have hemodialysis. And if they have enough problems with peritonitis, they will actually have to stop peritoneal dialysis. And peritoneal dialysis is certainly done at home. All right, so your book does also talk about continuous renal replacement therapy, or what we call CRRT. This is only done in an ICU, and this is ideal for unstable patients, because an unstable patient who is unstable on blood pressure, on lots of vasoactive medications, vasopressors, is not going to tolerate regular dialysis of 3 liters coming off in a couple of hours. So what they do is we gradually pull fluid. We have specific orders of how much fluid. Sometimes we keep a zero balance. Sometimes they want minus 100 every hour. And we're going to do this at the bedside. And so, I pulled this off the internet. And this is, hopefully you can see my mouse, the CRRT machine. These are our dialysis bags. This is what we call the P bag coming out of the patient. We've got two big catheters going, one going into the patient with inflow, one coming out with outflow. We certainly see lots of drips, pressure bags, and this piece right here is actually a blood warmer. So we do have advantages that it is ideal for these unstable patients, more gradual fluid removal, and that is good. We do have disadvantages. They can have fluid and electrolyte imbalances, but we draw their bloods every 12 hours and look at those, and I actually haven't seen that. They are at risk for infection because we are having to deal with these catheters. They will clot the filter. There's a little filter. It's kind of hard to show. It's right there. So they will clot the filter, which means we have to stop dialysis and redo it. They can get hypothermic because there's about 100 to 150, 200 mils of blood outside their body at all times as it's circulating through. They are at risk for air embolism, and it does require extra training for nurses. When a patient started on CRRT, they are a 1-to-1 because you are doing total I's and O's every hour so you can maintain that fluid balance. So you may get to see that in clinical. The good news about these machines is these patients can actually get up and walk around, and we just figured that out. Evidently, that's always been the case, but we weren't doing that. I also have seen a case where they will run CRRT during the day and then turn it off, let the patient have a break, and then start it up again. That's new. I don't know that that's very common because usually these patients need it continuously. The problem with the patient was he was just borderline hypotensive and was on and off of pressors a lot where they couldn't do regular dialysis, and we did this on and off against CRRT for a couple of weeks till he finally got more stable and we could turn his drips off. Lifespan considerations. So for infants, it's really who's at high risk, your preemies, low APGAR scores, babies with congenital heart defects. Those who recover may have some residual kidney damage and compromised kidney function. Children and adolescents, it's really pretty rare. It's usually related to some precipitating disorder. They will development of oliguria may or may not be readily apparent. They do have different manifestations. They'll have nausea, vomiting, edema, hypertension, lethargy, gross hematuria, so real bloody urine. Their problems, just like adults, imbalanced electrolytes, fluid volume overload, uremia, azotemia. So the treatment for them really is to give them isotonic fluid, monitor that response, and then actually treat the cause, and hopefully we won't have to do dialysis. Pregnant women, biggest cause for them to go into acute kidney injury is infections like a UTI, or things still related to what we talked about previously, like this hyperemesis that they have when they're pregnant where they can't keep anything down, so they become dehydrated. So they have hypovolemia, they can have hypertension, placenta previa, gestational diabetes, preeclampsia, eclampsia. We do need to treat any sepsis for them and treat postpartum hemorrhage because if they become hypovolemic, they could end up in acute kidney injury. Older adults, they're at risk because of comorbidities, things like diabetes, hypertension, heart failure. Prone to develop volume depletion problems, so they can really have problems with that. They develop that at volume depletion problems at less volume loss than younger people, and they will develop uremic symptoms at lower lab values, and they do have some atypical signs and symptoms. So those could be like an exacerbation of well-controlled heart failure, unexplained mental status changes, or personality disorders. Not disorders, personality changes. All right, let's talk about hyperkalemia. So normal potassium, 3.5 to 5. Critical value, your book says higher than 7. Certainly if you are hyperkalemic and come in at 7, we'll actually start you on dialysis to just get your potassium down. I would say a potassium of 6 or 6.5 would be critical, and I would be real concerned about that. 7 is like super concerned. Causes renal failure, potassium sparing diuretics, because they could, like spironolactone, could increase your potassium levels if we haven't watched that. Are they taking too much potassium? Adrenal insufficiency. Acidosis can cause hyperkalemia. Tissue trauma, like in burns, starvation. So what do they have? They're going to have tall peak T waves. Remember, in hypokalemia, we had flat T waves. This is tall peak T waves. So I found this for you. You can see that this T wave is almost as tall as the QRS. Then the higher the potassium goes, their QRS will widen. That's about a potassium of 7.5 to 8. And they will eventually widen out and go asystole. They will have some muscle weakness. They can have nausea, vomiting, diarrhea, abdominal cramps. And we've already talked about the treatment for them. Polystyrene sulfonate, D50 with insulin, and then calcium gluconate or calcium carbonate, or giving them a diuretic. All right, thank you.